Good morning Orlando, good morning ASH 2025. How wonderful to be here again. I am Moshe Mittelman from Tel Aviv. My co-chair is Professor Valeria Santini from Florence, Italy. And we are very happy to chair this MDS Foundation Myelodysplastic Syndrome session called Momentum in MDS, Making Progress and Shaping a Better Future. Before we move on, I was reminded to remind you not to forget to turn on your cell phone on your way out. And we can continue. And I would like to start by calling Mrs. Peggy and Torney, MDS Foundation CEO, to say a few words. Peggy Ann, please.
Good morning, everyone. Thank you for joining us this morning. Thank you for being here so early and for kicking off your ASH with us. While I know it is early, I also know that we have a wonderful, informing, and engaging program planned for you all today, one that we hope will challenge your thinking and help provide you with the knowledge you need to bring back to your patients so that we can improve patient outcomes together. Before we get started, I just want to take a few minutes to tell you a little bit about the MDS Foundation for those of you who may be new to us. The MDS Foundation is really committed to improving the lives of those who have been impacted by MDS. And we really focus on making sure that we can provide expert education, tailored and personalized support to MDS patients, that we're fostering innovative research and global collaboration, and that together we're building a community of support for our MDS community. The MDS Foundation is a global organization, and we have a presence in over 40 countries, connecting tens of thousands of healthcare professionals, patients, and caregivers to the information and the support that they need to navigate their disease with confidence. We provide a whole host of educational and support programs for patients and professionals, such as the one that you are here for today, to really make sure that patients and healthcare providers are empowered to navigate this disease. And so I ask all of you, as you're connecting with patients, that you tell them about the MDS Foundation and the breadth of resources and support services that we provide. We offer everything from digital resources to in-person education programs to global support networks and online community platforms to really help patients understand their disease, connect with one another, engage with one another to offer support so that they really can manage and live their best life. And with that, I'm going to turn it over to Dr. Stephen Nimer, Chairman of the MDS Foundation Board of Directors, to talk a little bit about our professional education programming.
Thank you, Peggy Ann. Good morning, everybody. Great to see people here this early. And if you look at your smartphone, you could see how many steps you've already completed in terms of getting here this morning. So you're probably at least halfway to your goal. I have an opportunity to just talk a little bit about what the MDS Foundation offers for professionals, physicians, nurses, social workers, others. We have, of course, the biennial International Congress on MDS, these Friday satellite symposiums, which occur every year before ASH officially starts. We've also been having regional symposia in the years alternating with the International Congress. And we've been launching a series of podcasts and webinars, and we would ask all of you for your ideas and to volunteer to participate in these activities. We were very thrilled back in May. We had the 18th International Congress in Rotterdam. At that time, we honored Peter Greenberg, who is shown here, and also John Bennett, who's in the audience, for their lifetime of contributions to MDS research and clinical care. We had about 400 people attend the meeting this year and had abstracts from 33 different countries, and it was a wonderful opportunity. to get caught up on everything unpublished and otherwise in MDS field. I'd ask everybody to save the dates. April 14th to the 17th, we will be in Leipzig, Germany for another MDS Foundation Symposium, the 19th International Congress. We have and continue to evolve working groups, professional working groups, the IWGPM, led by Peter Greenberg, which includes the IWG molecular, and also the MDS-MPN IWG, which is led by Michael Savona, and we're continually looking for new ideas. I'd ask everyone here to consider joining the MDS Foundation as a center of excellence or as a professional. You can use the QR code here, and we welcome everybody. Lastly, I'd like to thank our sponsors who have made this event possible, and now I'll turn things over to Moshe and Valeria. Thank you very much.
Thank you so much, Dr. Nimer. Thank you, Peggy Ann. Together with Professor Santini and MDS Foundation, Ms. Leah Harrison, and thank you, Leah, we have prepared a wonderful program for you. Believe me, I know the program, wonderful. And I would like to invite Valeria to say an overview of the program. Valeria.
Thank you, Moshe, and thank you to all the persons who came so early this morning. So one important thing we will ask you is to please complete the brief CMEA pre-test for today's symposium. There will be a post-symposium test as well, but this is very important for us. There are very few questions, so it doesn't take so much time for you. So today's program, it's quite intense and very interesting in our view. So we will have an overview of MDS Foundation guidelines. It's a global international effort that will be presented by Rena Buckstein. Then we have two debates. One debate on morphology. You know that the main stand and the standard of diagnosis of MDS still should stand or not. We have the debate on morphology. Then we have several cases to discuss and share with the super expert. So the debate will be between Robert Hasserjian and Arjan van den Loosdrecht, and the patient discussion will be presented by Howard Osler and Albert Kolomansky, and there will be the three experts, Rafael Bejar, Rena Buckstein, and Arjan van den Loosdrecht, who will help us to debate the case and discuss. The second debate, it's more on the germline mutation and the importance in evaluating these mutations in the diagnostics procedures. And then, of course, we will close with the therapy for MDS. So the discussion will focus on low-risk and high-risk MDS, on how to develop a new standard of care, how and what did we learn from the previous studies. And this will be myself, Moshe Mittelman, and David Stensma. So I hope you will enjoy our intense program. And with this, I'm very pleased to call Rena Buckstein to have an update on the new MDS international guidelines. Thank you.
Thanks, Valeria. So thank you very much for the kind introduction and for inviting me to be the ambassador for work still in progress of the MDS International Guidelines. This is a project under the auspices of MDS Right and the EU MDS Registry, the International MDS Foundation, and EuroBloodNet. And it's got the support of the scientific education support company called SES. These are my personal disclosures. These are disclosures of the University of York that's helping with these guidelines, as well as SES. So we all know MDS is a very heterogeneous disease. Every paper starts with that line, with a reduced life expectancy, sometimes a difficult diagnostic process, very widely divergent treatment options, and different access because of economics worldwide. We have a number of classification schemes and guidelines. The updates for some of them are not necessarily dynamic and immediate, and also guidelines may vary by country, again, possibly limited by access. We have 2 web-based treatment guidelines available, the NCCN, that is based on the consensus of experts. It's evidence-based, and there are yearly updates, but its primary purpose of existence is to encourage funding by not pharmaceutical companies, by insurance companies, as long as many of these drugs are listed as possible approvals for different scenarios. And there's sometimes confusing guidelines to follow. And they're also password protected. Not that it's such a difficult thing, you do have to create a password. Then there's MDS Europe, which I'll talk about in a second. That is available to everyone. It's in all European countries, but it was developed a number of years ago, mainly consensus-based and not completely evidence-based. So speaking specifically, MDS Europe, which was inspired by the MDS Right project, is endorsed by EHA. It was published in Hemisphere in 2021, and it is available and was available. And it's on this backbone that these international MDS guidelines is based. So Eva's vision, who was involved in the initial European MDS guidelines, was to provide an easily accessible source of information for healthcare professionals involved in the care of MDS, all healthcare professionals that are involved in the diagnostic and clinical management. We wanted to make these evidence and consensus-based, regularly update them, so make it nimble, open access, simple to navigate with bullets, and again, make it web-based and easily accessible on numerous platforms, including smartphones, and open not only to physicians and diagnosticians and nurses, but also to patients. So the mission statement is to increase the median and minimal level of quality of care for adult patients with MDS. And again, kind of this reiterates the same goals of the international MDS guidelines, to create an editorial board in charge of annual updates and eventually lead to a publication and other projects that will be directed to, for example, patients. Our target audience is very broad. You can see the list of our target audience, and it will be accessible and updatable. So we contracted with SES to help us with a literature review of 2014 to 2024, consulting both international documents like the WHO classification, as well as clinical trials, and informally assigned evidence grade and strength of recommendations. So it's not to the rigor of Gord Guyot from McMaster's company that helps provide the guidelines for ASH, but it's using a more sort of systematic approach to grading the literature as opposed to just consensus. Of course, in some instances, you can only rely on clinical consensus because we don't have randomized trials or sufficient evidence to give a high grade to the literature, but, and that's listed as well. The recommendations are flexible because, of course, there's limited access in some countries for some therapies, and we want to make it as practical and user-friendly as possible. And the nice thing about this website, which I'm going to now showcase to you, even though it's still in development, is it does link to key resources, and so it puts everything in one place and makes it very user-friendly. So this is we used what's called the grade evidence, rating things from high, moderate, low, and very low. So that would be 1, 2, 3, 4. And then for each one of these level of evidence, we assigned a letter A, B, C, D in terms of our certainty of the recommendation. The panel, there are 5 working group panels and chaired by the people highlighted in red. So we have panel 1, diagnosis, prognosis, and germline conditions. We have iron chelation, supportive care, transfusion, immunosuppressive therapy, and lenalidomide in working group 2. Growth factors, luspatercept, non-HMA low-dose chemotherapies in working group 3. HMA-based therapies and non-approved therapies in working group 4. And induction chemotherapy and stem cell transplant. As it stands right now, working group 1 to 3 have pretty much finalized their recommendations, and they are available, but I think there's still going to be some evolution in them. So again, there will be some changes in formatting and maybe some additional references added, but the guts of the recommendations are there and can be looked at. And 4 and 5 will hopefully be up by the end of January. I'm going to skip this slide because I just want to show the rigor with which the SES was tasked with the terminology that we helped inform their literature review. And then, the best thing I can do right now is just highlight how and demonstrate how this website works and how you can navigate it. So let's start with a case. You're in clinic. You have a 75-year-old male patient who's got some comorbidities. His brother had lung cancer at the age of 70. His sister had breast cancer at the age of 65. He's good performance status, no bad habits, and the history of present illness is that he's had progressive macrocytosis and mild thrombocytosis for 5 years. His blood counts in 2021 were completely normal, and he's asymptomatic, but on examination in his annual follow-up, he has anemia, a moderate anemia. He's macrocytic, he has anisocytosis, and his platelet count is kind of borderline elevated. So I'm going to then demonstrate real-time how you would use these guidelines. This is the link. And there's a disclaimer. So this is the web page that you'll arrive at, and it can be navigated in 2 ways. There's sort of diagnosis, prognosis, and treatment buttons, and there's also a navigation panel on the left. So we want to know what this patient, how to approach this patient, and how to what tests to order, what to consider, and then how to treat this patient. So I'm just going to click on the About, and the About button takes you to the preamble I just provided to you about who's chairing what committees and who's involved in what committees, and the methodology that was used. Now we're going to go to Diagnosis. And so we have 3 buttons: Diagnostic Workup, Classification, and Germline Conditions. And I have to say, I think the Working Group 1 panel members have done an excellent job at making this as user-friendly and helpful in the clinic as possible. And I definitely plan on using this and demonstrating this to my trainees. So let's click on Diagnostic Workup. So it tells us that it's a difficult diagnostic workup, and it provides you an interactive workup flowchart with different links for the different sections. And obviously, I'm not going to go through all of them, but you can see how robust this is. So for example, if I click on cytopenias, it gives me a definition of what a cytopenia is and what a cytosis is. In differential diagnosis for the diagnosis of MDS, it shows you what you should consider and what your trainees should consider in working up somebody for macrocytic anemia or other pancytopenias, and what investigations would be useful to perform. In now we come down to suspected MDS or MPN. But I'm going to also point out the germline predisposition, because you remember the patient has 2 siblings with cancer. And you can't remember, should I be screening this patient for germline mutation, even though they're older, because they do have 2 family members with a history of cancer. And so this is really helpful, because this is not something that's always readily available in our minds. So there's a definition of what germline predisposition syndromes are, what the most common ones are in children versus adults, for example, DDX41. And there are tables that direct you and diagrams that direct you to know when should you screen and when shouldn't you screen. So for example, so it says screening for germline conditions should be considered in the following settings. And so it tells you what to do in terms of screening: personal history assessment, MDS below age 50, hypoplasia, the patient has a personal history of primary cancer, any systemic findings suggestive of hematologic malignancy, any potentially germline variants in the next generation sequencing, and so forth. And then you're instructed also to take a 3-generation family history assessment for any of the following that are listed here. And then if you have 1 or more personal or family history, then you should consider dedicated hereditary genetic testing versus not. And then with regards to the different genetic variants and how they're defined and how the ICC and WHO classifies them, there's a nice link for the genetic predisposition classification. So I'm just going to there's also directions for physical examination, history and history conditions, as well as physical examination findings that you should consider in your exam of the patient. So this is fantastic for our trainees. All right, I'm going to leave that. Okay, so we've ruled out all reversible causes, and we've decided based on the guidelines that we don't need to do germline genetic testing. And now we have the suspected MDS or MPN. So the diagnostic evaluation should include a bone marrow, microscopic exam of adequate bone marrow, karyotype and mutation analysis, as well as examining the immunophenotype. Okay, so I'm going to close this. Okay. Okay, so you do a bone marrow aspirin and biopsy. It's 90% cellularity. The CD34 blasts are 2%. There are micromegakaryocytes and dysplastic erythropoiesis in 20%. These are cytogenetics. And you do NGS with a 40-gene myeloid panel, and there are tier 1, tier 2 variants in TET2 with a VAF of 20%, and STAG2 with a VAF of 10%. So now we want to know, how do we classify this patient? So we go to diagnosis, and back to diagnostic workup. Nope, 1 second. Classification. Okay, so under classification, you click on digital classifier, and you can basically enter what you know about the patient. Blasts are 0%. There's no NPM1 mutation. There's 0 TP53 mutations. There are no RUNX1 mutations. There are no SF3 beta 1 mutations. There are no AML defining cytogenetics. There is deletion 5q. There is no 7q deletion. There's no monosomy 7. And there's no complex karyotype. And then it gives you the final diagnosis. So in the ICC, it would be MDS with isolated del5q. In the WHO, it would be MDS with isolated del5q. So now we want to figure out what the patient's prognosis is. And the patient, of course, wants to know his prognosis. So you click on your link, and you have it probably open in the background. And then you can go to online calculators. And there are the IPSS available, the IPSS-R, and the molecular IPSS-M link. And I'm not going to walk you through that because it's time consuming, but when you do use that link, which is very helpful, you conclude that the patient has a low IPSS-M score of minus 1.01, the IPSS score is 2, and the IPSS-R score is 2.2, and it gives you what the LFS, OS, and AML transformation rate is. So now we want to think about treatment. The patient has moderate anemia of 95. So under treatment, we have the following boxes available to you. And you remember the MDS 003 and 004 studies studied lenalidomide in patients with deletion 5q that were red blood cell transfusion dependent. But you want to know, is there any evidence in support of somebody who's not red cell transfusion dependent? So you click on that button for lenalidomide, and it gives you what the indications are, the approved indications, and what the benefit is, prolonged survival in patients obtaining a response, the fact that patients with a high TP53 VAF or multi-hit loss are at increased risk of leukemia, that patients who have a concurrent SF3 beta 1 mutation don't do as well, and when you should not consider to use lenalidomide. Response is assessed using the 2018 criteria, IWG 2018 criteria, and we will be providing a link to that as well. And then some general aspects of treatment, very simple, practical recommendations in terms of what starting dose should be, what the cytopenias mean in the first few cycles, and why that's a positive predictive sign, and that you should not thromboprophylax. And then how to follow the patients with regards to serial blood counts, when you should repeat the bone marrow, and what you should consider in case the patient loses their response. And time doesn't permit me to walk you through every single one of these guidelines, but in the end, and that's what you can do at your leisure, but this is what it's intended to be. It's sort of practical, quick, available to you in the clinic at all levels of training. And then the recommendation levels, so A1 for IPSS low and intermediate 1 with isolated deletion 5q that are transfusion dependent. And again, IPSS low and int 1 with del 5q and 1 additional chromosome abnormality not involving chromosome 7 or 17 and transfusion dependency. But then there's also the preamble about possible other indications of lenalidomide in lower risk that are without red cell transfusion independence, citing the Sintra-Rev study and what the benefits were from that, as well as patients who are red cell transfusion dependent without deletion 5q and what the evidence is for that. And then one simple bullet about higher risk MDS with isolated del 5q, although there is very limited knowledge. Okay. I'll just highlight one more case and then conclude. Here's a 75-year-old patient. We're done? Okay, so time doesn't permit me to do this, but I think you got a good taste of how the website works and how you can navigate it, and we encourage you to play around with it. Okay. So our next steps are we're going to have a large review of all the working groups by all the working groups in January. We have to hopefully have a complete draft and an EHA abstract by March 1st, and then we hope to launch it. So just still a work in progress, but getting very close to finalizing it. Please bookmark this and share this with your colleagues and students and staff. Please provide feedback at the links provided on the website or to the emails below for improvements or what you would like to see. And it will definitely evolve over time. And I thank you for your attention. Yeah, no worries. No worries.
Thank you so much, Rena. Also on behalf of Eva Hellstrom, who could not be here today. We move on The world is changing, and when I look at my children and grandchildren, I understand it even better. And our field is also changing all the time. New information, genetics, digital data, and so on. So this raises many questions. One of the most interesting questions in our mind is morphology still the basis for MDS diagnosis and follow-up? Rob Hasserjian from Mass General in Boston would like to tell you that the answer is definitely yes. He's sure about it. I guess that John Bennett agrees, and many others. But Arjan van der Loosdrecht from the Netherlands, from Amsterdam, tends to disagree. So, Rob, please, tell us why.
Thank you very much for inviting me to speak. I just want to have a little correction. I think I was actually assigned to argue no and Arjan's going to argue yes. I'm the no person. Okay. Or maybe we're both no, I don't know. But anyway, I think we all can agree in the end the truth is somewhere in the middle. But okay, so is morphology still the basis for MDS diagnosis and follow-up? There we go. So you can think of it as a tug of war, but I think as you'll see from the end of this, hopefully I think morphology and other techniques like flow cytometry and molecular studies can, I think, harmonize together in how we decide to define and follow MDS. So I'm going to be arguing on the side of non-morphology, mainly genetics. These are my disclosures. So we all know very much and think we all agree that MDS has a genetic basis, and we know how it develops from normal stem cells that acquire mutations. We term CHIP, clonal hematopoiesis of indeterminate potential, initially do not perturb the counts. The patients then subsequently develop cytopenia as the clone expands, and then something happens and the patient progresses to a disease that we're willing to call MDS. And that is defined right now by whether a pathologist sees dysplasia under the microscope. If we don't see dysplasia and we have a certain mutation profile with a cytopenia at CCOS, if there is dysplasia, as shown in the image, it's MDS. And I'm going to argue that perhaps we should think about CCOS and MDS more together and instead define a disease more by its molecular features in cytopenia, that is how it affects the patient, rather than whether a pathologist sees dysplasia under the microscope. So I think these lie on a continuum that are right now separated by the presence of morphologic dysplasia, and we use a threshold of 10% dysplastic cells. If I see more than 10% dysplastic cells, and there are some images below, in any lineage, erythroids, myeloids, or megas, I'm allowed to call it MDS. However, this is an imperfect diagnostic feature because it's not always reproducible, as some studies have recently shown, even by experienced hematopathologists. And also, it's not specific for MDS. We can see many dysplastic changes caused by other things like alcohol, HIV infection, some drugs, inflammatory conditions, and these can really mimic MDS morphologically. In the real world, patients often have some of these comorbidities, and these elderly patients can have the same conditions that cause dysplasia and cytopenia, that also the elderly patients have higher risk for MDS. And also, as we all know, in the real world, unfortunately, bone marrow samples are sometimes suboptimal, impairing the ability to accurately identify dysplasia, which can be very frustrating as a pathologist trying to look if the cells are not well spread or whatever, or if it's a very tiny biopsy, I can't see the megakaryocytes, it's hard for me to be sure if there's really dysplasia. So do we really have to see dysplasia to distinguish MDS from CCOS? And why is this relevant? Because higher risk CCS patients may benefit from closer monitoring and even treatment perhaps if they're really cytopenic. And there are a number of studies that have now dug into CHIP and CCOS and have developed risk models that progression to myeloid neoplasia and survival. And emerging evidence is showing that the more mutations predict worse survival. Clone metrics like higher VAF and mutational patterns or co-mutations predict outcome. And in fact, some studies have shown that high-risk CCUS, essentially these patients have similar overall survival to lower-risk MDS patients, begging the question is whether these are really truly different diseases based on whether or not I see dysplasia under the microscope. The other thing is we think of related disorders to the MDS versus CCUS conundrum. Sorry, the slide is a little bit cut off. We think of things like CLL, large granular lymphocytic leukemia. MDS is defined by morphology. However, the other diseases are defined by quantity. For example, having 5,000 cells in the blood for MDS, having a certain percentage of plasma cells for myeloma. And this, perhaps we should consider more of a quantitative definition, like the size of a clone, rather than whether the clone is causing dysplasia that we see. So what about classifying MDS? This lists the current myelodysplastic syndromes or neoplasms in ICC and WHO. And indeed, several, as you're all aware, 3 genetic subgroups are recognized that are now defined essentially by their genetics or classified by their genetics that supersede morphology. However, about 3/4 of MDS cases remain morphologically defined when using the ICC and the WHO. We know the existing subtypes of MDS are robust disease classifiers, as shown here. The morphologic associations, distinct prognosis, predictive patterns of treatment are all true for all of them. Sorry, the slides are, for some reason, getting cut off at the bottom. I'm not sure why, but in any case, and by unsupervised clustering showing different disease expression profiles. So we know that those 3 subgroups are definitely really important. However, perhaps we can consider developing more genetic subgroups. So we asked the question, can we now arrive at a fully genetic MDS classification? And a number of studies are now using unsupervised machine learning to molecularly cluster cases and avoiding the inertia of sort of bias in a morphology-based scheme that we have originally inherited from the FAB, can classify these now in distinct groups using purely genetics and in fact arrive at distinct subgroups. These models have validated the existing MDS subtypes like deletion 5q, SF3B1, and P53, but have shown other unique subtypes not previously recognized that have particular patterns of progression as shown on the left, and also highlighting within the kind of what I call wastebasket of higher risk MDS with excess blasts, distinct groups, and yet these are all right now classified together in a single morphologic group of MDS with excess blasts. Other studies have looked more broadly, like the study by Kwan et al. That looked at the diseases across the spectrum of MDS and AML, showing that, in fact, you can see clusters that emerge from molecular assessment that actually cross a broad spectrum of blast counts, including the MDS and AML divide. And in some of these genetically defined clusters, blast percentages do not affect prognosis. And this brings up the study by Huber et al., which developed a scheme, although this was prognostically based, that was able to actually account for prognosis based purely on genetics of a particular cohort of MDS patients from the MLL. So then we finally arrive at the paper by Bernard et al., which developed a molecular taxonomy of MDS, which was agnostic for morphology. And this was based on a series of genes, and in the end, 16 molecular groups were devised, which were mutually exclusive based on the machine-derived rules, and were based on both cytogenetic and molecular mutational analysis. And these classes were indeed very different, not only the recognized classes of 5q, P53, and SF3B1, but several other classes that had differences in their clinical expressions like cytopenias, age of the patient, associations with monocytosis, and associations with increased blasts, and also had significant associations with patient outcome. So here I'm arguing that perhaps we should adopt such a purely genetically based scheme, but then what is the role of morphology? I'm a pathologist. Am I talking myself out of existence and making myself obsolete? Well, I think morphology still does have a role, in fact. Blasts are still important in prognostic schemes. Studies have shown that fibrosis, cellularity, and single versus multiple dysplasia all have impact on prognosis of MDS, but I would argue that these are more sort of more staging or sort of maybe qualifiers to the genetic disease. For example, we think of different types of renal cell carcinoma, but we stage them all based on how wide they've spread. I would say we should classify MDS by their genetic groups, and then the stage is how many blasts there are as it's progressing towards AML. And this is how this could work in practice, perhaps a goal to think of for the future that I might advocate is attractive. If we have a patient now, 65-year-old female with anemia, we do a bone marrow, I count 6% blasts, let's say. Genetics comes back with an isolated deletion 5q, and in fact the megakaryocytes here look typical for that entity, but also a P53 monoallelic at an 8% VAF. This looks like it could be MDS with isolated deletion 5q, but it technically has excess blasts. So we would just call it, put it in that wastebasket of MDS with excess blasts. But I would argue in the future we should consider this to be a type of MDS with deletion 5q that's in an advanced stage. And as we heard from Dr. Buckstein's lecture, perhaps these patients might respond to lenalidomide, and we should think more about targeting genetic pathway rather than just a particular treating a blast count. And the monoallelic P53 can tell us that, as we know from studies, this patients need to be closely followed for transition or transformation to an aggressive myeloid neoplasm with mutated P53. So in conclusion, I think, again, we're actually fortunate to have multiple tools to interrogate hematologic diseases. We have morphology and clinical features, and now more recently, as you'll hear from Arjan as well, immunophenotype and genetics. And it's up to us to decide how to define MDS and characterize it to decide how best to treat these patients. I would advocate that MDS is inherently a genetically driven disease originating from a mutated hematopoietic stem cell. Hematopoietic clones that cause cytopenia, I believe, should be considered equivalent to MDS, no matter what I see under the microscope. The unique signature, and I borrow a term from Sid Mukherjee's excellent book, Emperor of All Maladies, stitched into the genome of the cells, provides a more, I think, robust and objective way to understand the disease than what I'm seeing under the microscope, because it really indicates the origin of the disease and what's causing the clone to behave badly. I would argue that morphologic immunophenotypic features are complementary and provide important prognostic information, such as stage, that can be useful to follow the disease response to treatment. But I would argue should not be the primary way that we classify the diseases, as we're currently doing for most cases. So with that, I'll thank you for your attention. And this is my city that's right now 10 degrees Fahrenheit, so I'm very happy to be here.
Sit with us. Maybe you will have something to say later. Thank you. Arjan, explain to us why do you disagree? Be careful.
So, first, I would like to thank Valeria and Moshe for the kindly introduction, as well as by asking me to show you that it is not all molecular. And since John Bennett is in the room, it's not alone morphology, but still morphology is important. So, the question is it still the basis? And I have some doubts, and maybe we can do better with flow. So that is why I would like to highlight that once the diagnosis is potentially visible, you should have a cytopenia. That's the basis. And then we all know already the discussed criteria as dysplasia over the 10% in one or more lineages, ring sideroblast, this is not too much. You might have an SFD mutation or an increase of blasts, etc., and specific chromosomal abnormalities. But already we know for years that there are co-criteria. And already years ago we postulated that an abnormal immune phenotype of bone marrow cells might add to the diagnosis of MDS. But at the end, I will plead for an integrated diagnostic approach for morphology, the cytogenetics, the molecular background, as well as immunophenotype. But it is not there, the flow, because it was already highlighted by Robert, the both in the harmonization of the WHO and the ICC, we have molecular defined entities, like the TP53 mutation, like the DEL5Q, like the SLBB1, but it's only 1/3 of the patients identified. And then we have the morphology. But how can flow add in that diagnostic process and in the classification? And it is already in a former WHO classification that it was recognized as important, because the diagnostic evaluation should consist both on the smear or morphology, the chromosomal analysis, and immunophenotyping evaluation. It's already in the Blue Book. And also with patients with low blast counts, it was already highlighted that flow may add to characterizing the immature progenitors, as we do in MRD in AML, for instance, and also looking to the maturation processes of the neutrophils and the monocytes. But the blast cell count is still for the morphologists. It cannot enumerate it by flow alone, it was said in the WHO book. But we do encounter major problems in the diagnostics on a daily basis, because we do see a lot of patients with cytopenia, the hallmark of MDS, but with mild dysplasia and no disease-defining molecular abnormalities. Dysplasia is subjective with a high inter-observer variability and not specific to MDS. And note that in low blast count disease, the cytogenetics are mainly not informative or fully normal. And mutations are not per se defining MDS, which was highlighted already by Robert, named the DTMT3A, the A6L1, and the TET2, the so-called CHIP mutations. So what is flow about? If you look to the left panel, and you look to a specific graph of flow specialist, CD13 against CD11b, and what you see a pattern of differentiation. And in normal hematopoiesis, the antigens during maturation follows always the same direction. But in an aberrant dysplastic bone marrow, there are different expression levels during that maturation processes, not only on the immature level, but also on the maturing components. And this can be fully standardized, recognized. And therefore, we came up with a recommendation panel focusing on the myeloid progenitor cells, the lymphoid progenitor cells, the maturing granulocytes, the monocytes, as well as the erythroid lineage. And then you can, by adding or by using these recommended markers, you can identify patients with a normal hematopoiesis versus an abnormal hematopoiesis predictive for MDS. So by focusing on the percentage of myeloid progenitor cells, it was clearly found that an increase with or without hemodilution of blast cells by the flow cytometry is highly predictive for MDS. But more important is abnormal phenotypes, like the so-called leukemia-associated immune phenotype, which can be used also in MRD follow-up in AML, as well as the abnormal differentiation patterns. These are all defined. And in this case, for a patient with cytopenia, we use the Ogata score. It's a quite simple score, and I hope I cannot, pointer is not working, but if you see to the right panel, you can see in blue the progenitor cells by CD34 enumeration. It's normal, but there is a fully absence of progenitor B cells, which is in part age-related, but also typically for MDS. And in the left panel, in pink, you can see, or in purple, that the side sketch of the granulocytes, which is a hallmark of MDS by the microscope, is decreased as compared to a lymphocytic control. And by pointing out such quite simple flow cytometric assessments, you can identify MDS versus normal quite easy. And in a more integrated approach, you add up to 44 parameters. And that is the problem, because many of you think that is too much and that is too complex. But what it says is that a simple Ogata score, by adding a lot of other scoring systems, may increase the sensitivity and specificity of the analysis. In a so-called ABC score, that means dependent on the dysplasia score you enumerate by the flow cytometry, you can identify results like A, do not show any MDS-related features, or as C, results are consistent with MDS. But to make it a little bit simpler, you can use only 12 antibodies and only 17 parameters. And this huge international multi-center trial within the European Leukemia Net showed that we could identify a couple of specific immune phenotypic features, 17, as well as the enumeration of the blast cell counts, which can account for over 90% with a sensitivity of 85% of MDS versus normal controls or fully normal bone marrow. And it is fully validated in 2 independent cohorts. And note, in the middle, you see the very complex integrated flow score, and in the right, the quite simple European Leukemia Net score. And the middle panel shows you a mainly in low-risk MDS, that you can identify over 85 and also with the ELN score, 86% of the patients with MDS by a rather simple score. And this can also be fully automated. By a computational analysis, look to the right bottom, we could identify with a single tube only some antibodies mainly focused on erythroid cells and some progenitor cell populations, that the sensitivity or specificity of over 90–95% could be established to rule out MDS versus non-MDS. And by a computational approach, fully automated, you can also show that specific features could be identified which were not otherwise identified by the microscope or by conventional flow cytometry. And mainly in the left bottom of the slides, you can show the granularity of the precursors of the red blood cells. The scatter, like the scatter in the granulocytes, we can also have the scatter on precursor erythroid cells. And it's a new feature which was also validated in other independent ways. So finally, I show you an example of a patient with a cytopenia, which we focus on the blue cells, the CD34 positive cells. And if you look to the C panel, the right panel, you can see that a lot of antigens which are normally not expressed in that way on healthy bone marrow cells are expressed on immature progenitor cells, the so-called leukemia-associated phenotypes. And what you can recall from this, in this patient with cytopenia, there was no evidence of dysplasia, there was no increase in blast cell counts, but there were dramatic aberrancies on the immature progenitor cells. And within a half a year, it was an overt MDS, and even high-risk MDS evolved. So the algorithm, finally. This was already just published by Marco Fati and Mario Cazzola. If you have a patient with a cytopenia, an unexplained cytopenia, where you have ruled out a lot of other issues for cytopenia, and you have a clonal cytopenia, you see also in the left part of the box that flow has an important role to rule out, for instance, other causes, as well as to include ways of diagnosing MDS. And a very important Danish group showed that in the presence in a cohort with patients of CICUS as well as MDS, it was shown that aberrancies based on flow cytometry could, with a negative predictive value of over 90–95%, rule out the existence of MDS, pointing the fact that the patient with cytopenia, with the clonal cytopenia, which was clonal, which do not have MDS-specific abnormalities by flow, does not have MDS at all. And that is, I think, a very interesting contribution of flow. How can we use that? The last slide. If we have a patient with cytopenia, with a possible MDS, we have ruled out the most elegant causes like iron deficiency, etc. I position the microscope and the flow centrally, and then dependent on the abnormalities found, we can then go to a refine, we can go to a more extensive molecular profile or to even a more complex flow cytometry assay, and then within an integrated reporting, we can give the final diagnosis of MDS. So to come to a conclusion, I think that the morphology is still a major issue to rule out a lot of quite simple issues, and then we move on with either the molecular biology or the flow, and at the end, and together, an integrated reporting. Thank you.
Thank you. Any big comments, Dr. Hasserjian?
No, I think we're saying the same thing. I think we have all these techniques available, and the question is just how to best combine them in terms of arriving at a diagnosis and helping clinicians, or helping you all deciding which patients you want to treat and are amenable to treatment.
Thank you. Last words, Arjan?
Yes, I think that is right. And note that most of the patients are not molecularly defined still. And therefore, and mainly the patients with cytopenia and an underlying clonal disease, also the negative predictive value of flow is contributing to rule out in MDS. It could be time, but at that moment, it's not the case.
Thank you. I'm sure we can continue to debate, but with the interest of time, thank you so much, and we will move on. Thank you.
It was a short debate.
Okay, and now we come to the discussion of cases. So the first case is by Howard Oster, and I would like to call the debaters, so the expert panel of Rafael, Bejar, Rena, Buckstein, and Arjan. You don't move, you come back immediately. And we are really anxious to listen to the cases. So in the interest of time, the cases will be 5 minutes, and then 15 minutes for the discussion. So lively discussion, I hope.
Where's the Right, I see that.
Yeah.
Right. No, have to go back one? That. Okay. Good morning, everybody. I'm Howie Oster from Israel, and I'd like to present two cases of patients with high-risk MDS. So we'll start with patient number one. This is a 70-year-old woman who presented last year with weakness, fatigue, and weight loss, about 10 kilograms. She has a past medical history of hypertension, hyperlipidemia, very heavy smoking history. On physical exam, she's pale, she's cachectic, and she shows signs of her smoking history with wheezes and prolonged expiration. On laboratory, she has a mild anemia that's macrocytic, mild leukocytopenia, and neutropenia. Her platelets are fine. And on bone marrow, she has hypercellularity with trilineal dysplasia and blasts of 12% with a karyotype of del5q. NGS shows no mutations. So she was diagnosed with higher risk MDS, and we asked whether we should treat her with azacitidine, whether this is the time for transplantation. Well, azacitidine was initiated. We asked at that point, should venetoclax be given, and we decided no, or not yet. So she was treated with azacitidine. She did not tolerate it that well. She had decreased counts. She had reduced doses to modify, and she had delays in treatment. She had infections, admissions to the hospital, and she was given supportive care with RBC transfusions. After 6 cycles, somehow she managed to complete those. She had improved symptoms. She gained weight, but she was still anemic, but she did not require transfusions. Her bone marrow at that time showed 3% blasts. So we asked, what now? Should we continue with the azacitidine? Should we think about transplant at this point? Well, while we were deliberating during the course of about 2 to 3 months, she had symptoms again and started losing weight, and her blasts were up to 7%. And so she was given azacitidine for 3 more cycles, again modified in terms of doses and timing. Still poorly tolerated with supportive treatment required, but after 9 cycles, she did achieve some sort of stability. She had mild symptoms, but she was active. She required RBC transfusions, but about every 3 to 4 weeks, and her hemoglobin remained about 7 to 8. Her blast at the last bone marrow was about 6 to 7%, and she still had the del5q. So now we ask, what next? Well, before we discuss that, we're going to go on to the next case. This is a 74-year-old man who presented in 2017 with asymptomatic anemia. He has a past medical history of hypertension, hyperlipidemia, diabetes, coronary artery disease. His exam was normal, and on bone marrow, he just had mild dyserythropoiesis with blasts of about 1%, normal karyotype, and he was diagnosed with very low or low-risk MDS, and the management was just follow-up. Fast forward to 2023. Now he has symptoms, weakness, fatigue. He's anemic, macrocytic. He has leukocytopenia with mild neutropenia, and you can see that his platelets are dropping to 95. His bone marrow is similar, but with these blood counts, we have concerns. And the next year, 2024, remember that he's now 81 years old. His symptoms are worse. His blood counts continue to drop. His bone marrow shows hypercellularity with dysplasia in both the erythroid and the myeloid lines. His blasts are now 11%, and his NGS shows TET2 with a VAF of 35%. So now his management is clearer, and he's given azacitidine. He manages 6 cycles, does not tolerate it that well like the first patient, and requires reduced doses, and treatments are delayed. He has supportive care. But when he comes into the clinic, he says he feels better, he's active, he has bone marrow that shows blasts of about 6%, and we decide to continue the azacitidine. And after 10 cycles, he feels okay. He says in the clinic, I feel okay. And his hemoglobin is about 7.7. It's significantly lower. His ANC now is 800. His platelets are 16,000. He requires RBC treatment every week or two, GCSF, platelet transfusions. And his most recent bone marrow, his blasts are 7%, and the NGS shows a TET2 that went from 35% to 44%, and now he has the EZH2 with a VAF of 50%. So now we ask in both of these cases, what's next? And I'll put up the questions that we want to discuss. Number one, we talk about the comorbidities. What is their role? Do they have an impact on the prognosis, and should they be part of the classification? Do they affect treatment decision? When we give hypomethylating agents, should they be given alone or in combination of others? And what is the role of venetoclax now, especially where we stand now after studies of the Verona in 2025? What about transplant? What's the timing? What is the appropriate age or the age limit? Do we require complete remission? Should we treat with azacitidine beforehand? What about the patient who's transplant ineligible? What do we do for him? And what's the recommended approach for patients that are in partial remission? And of course, with all these, what we presented with those 2 patients, which are similar to many of our patients, the azacitidine side effects, what do we do about it? And is there a significance, finally, is there a significance to the VAF that increases? Lots of questions. Good luck. Thank you. Wait, let me keep that last slide on.
Thank you very much.
I'm going to put those questions back on.
I think we'll just...
So brave to start. Rena.
Okay. So,
Okay.
Thanks, Howard, for these cases. And, these are typical cases that we see in our practice all the time. So specific to comorbidities, absolutely comorbidities play a role. They independently add prognostic value to the IPSS, the IPSS-R, yet to look at the IPSS-M, but I predict that they do. But probably even more important would be frailty. And because some patients are comorbid without frailty, and some patients are frail without comorbidities. And in work that we've done in the National Registry in Canada, we've shown that frailty actually supplants comorbidity. And in fact, the only comorbidity that was important in a frailty-specific metric for MDS patients called the FS15 that we developed, the comorbidity that was important was previous cardiac disease. So it is important, but if you had to choose between doing a frailty measurement versus comorbidity, I would say frailty would be important. Now, with regards to eligibility for transplant, no question, the HCTCI is used readily by all transplanters to determine whether or not someone should or should not have a transplant. But I want to direct people to this new measurement called the CHARM measurement. And there was a lovely paper that was recently published by LeBlanc et al. Evaluating the impact of CHARM at predicting not just non-relapse mortality, which is what it was developed for. And by the way, the CHARM is comprised of not just the HCTCI, but also weight loss over the prior year, Karnofsky performance status, CRP, albumin, cognition by MoCA, and patient age. And the CHARM, which not only predicts NRM, also predicts frailty and disability-free survival. So in terms of counseling your patients, how well they're going to be, even if they survive the transplant, the CHARM has been validated to be very useful. So absolutely.
Yes, Valeria? It's quite clear what you have said. If you go back to the patients specifically from Howard, thank you for the cases, Howard. The patient's first patient of 70 years old with a lot of comorbidities. So I can argue also that a transplant was not the best way in a del(5q) in that specific way. If you look to the del(5q), now at the end, patients after azacitidine, the only aberrancy is still del(5q) with low blast count. It might be considered to use lenalidomide in this specific case. So although in the beginning there was an increased blast count over in your document, it was first 10%, but now it was 12% on your slides, okay. If you calculate that with the IPSS molecular by the isolated del(5q, you might argue to start with lenalidomide, and even now after ASA failure. So that is a discussion I would come up.
But the blasts are 6 to 7%.
Yes, that is high, and according to the registration, to the criteria, it's not an isolated del(5q per se, or a little bit more. But on the other hand, there is no signs of further cytopenia except for the anemia. So you might consider, because transplant, by what Rena was saying, was not a possibility, I think, in this case, due to the comorbidities, the cardiovascular disease, it might be an argument. But maybe...
I think those are reasonable options to consider. I think one of the things we have to think about is what are our goals of treatment. I think initially when you treat a higher risk patient, the idea is to not only reduce the blasts, but to improve survival and of course improve the blood count so the patients are no longer transfusion dependent. But if we can achieve any of those things, I think we're accepting of that therapy, might continue it while that's the case. So one option is to continue what you're doing and support the patient and move on. But I do get concerned that that isn't going to work long term in a patient who has excess blasts. And you raise the question of whether venetoclax might be appropriate for this patient. We know the top-line results of the Verona study were negative, but it doesn't mean you have to give the patient a regimen that's exactly like was in the Verona study. Venetoclax is particularly effective at reducing blast count, often within a single cycle of treatment. And even though these patients have a lot of comorbidities that might preclude them going to transplant, you might be able to find a way to combine it with venetoclax to reduce the blast count, perhaps improve the blood counts, improve the transfusion dependence. And that's something that I would consider in a patient like this with careful monitoring during that first cycle, given their experience with AZA alone.
And Dr. Garcia Minero's presenting a subgroup analysis from the Verona study at this meeting in an oral abstract, and definitely showed that there are certain subgroups and certain genetic subgroups that seem to benefit more from Verona, as well as younger patients. So this patient less than 75, and this patient was less than 70. I mean, I think at the front end, it's, again, without really seeing what the patient looked like, what their performance status was, I wouldn't say transplant was off the table just because of those comorbidities. So if the goal was to get to transplant, I would agree that's probably the quickest way of achieving that.
Yeah, I think in general also the kinetics is always very important. What's how evolving the blast counts. In both cases, you have a reduction, a major reduction of blast cell count. So you might argue that the blast reduction makes no sense specifically in these cases you presented. Also in the old 81-year-old man, the toxicity of ASA could be maybe a little bit handleable, how do you call that? Manageable.
Mitigated.
Because of mitigation of the dose. 50% reduction, but not every 4 weeks or less. And then normally the toxicity, the myelosuppression or other complaints might really go down. So there are possibilities as supportive care maximum, disease control, in this case, no kinetics, so venetoclax might not be an option because also you don't go to a transplant, and there are the arguments, I think.
I think one of the questions was, should you stop azacitidine in patients? And I think that, the consensus is that most patients will relapse quickly if you stop azacitidine. You're not eradicating the clone. You're suppressing it, but you're not eradicating it. So it shouldn't be, but as Arjan said, you can kind of play around with the dose and the schedule to make it more tolerable for the patient. Sometimes even 6-week intervals. Some patients very far out. I have patients who've been on AZA for 2.5 years, coming every 6 weeks, and they're getting a slight 5 days instead of 7 days. So there's an art to giving azacitidine. GCSF can be used if you've had a blast reduction as well. But it shouldn't be stopped. The patients who have been on it for at least 12 months, however, have better progression-free survival than people who have been on it less than 12 months. So definitely don't take patients off before 12 months. And then,
I want to hear about what Rena just said regarding the clones and the importance of the oscillation.
About whether you have to clear the clones to do anything. I think it is there is an association with improved outcomes in patients who do have a reduction in their clonal burden of disease. But it is clearly not a requirement for that to happen in order for patients to receive benefit from the hypomethylating agents. There are some patients who do get some improvement in blood counts without any change in clonal size or even with clonal evolution. So I wouldn't use that as a gauge for what to do with therapy necessarily, although when you do see the clonal reduction occur, then you're likely to have a more prolonged remission or a prolonged degree of benefit. But with regard to transplantation, I don't think you need to achieve that before you go to transplant. You certainly don't need a CR, you certainly don't need clonal reduction. Those things may be prognostic of outcomes after transplant, but you can certainly just proceed to transplant if that is an option.
Right.
And I think there was a published ESBMT study a year or two ago that looked at the impact of reducing the risk score prior to transplant with either intensive chemotherapy or hypomethylating agent. And the party line was that the outcomes of patients that were untreated were just as good as patients that were treated who either stayed stable or had improvement. But the patients who got treated and had either with hypomethylating agents and either had worsening of their risk score or progression in their disease prior to their transplant did worse. But I think the conclusion was you actually don't have to treat patients to get them to transplant. The major problem is, as Arjan said, is kinetics. So if someone's blasts are rapidly increasing from month to month, that's a patient, you're not going to get them to transplant in 3 weeks. And so you do want to kind of control things for a while, so HMA would be warranted. But in someone with like 8% blasts, that's kind of stable, counts are stable, I think you don't necessarily have to consider giving hypomethylating agents. There's no evidence, at least from this retrospective data, that debulking them improves their outcome.
I note it was retrospective. I would highlight it because it was not prospectively randomized and therefore some reluctance, but I fully agree kinetics is, I think, important in that perspective.
Okay, thank you very much for the first 2 cases. And then I call Albert Kolomansky now for the lower risk MDS cases to discuss.
Right. Move the slides.
The green one.
This one, okay. Okay, good morning, everyone, and thanks to the organizing committee for giving me the opportunity to present these 2 cases. So the first one came to our attention in 2021. This is a gentleman. He was back then 65 years of age, complained of some weakness and some fatigue. This is his past medical history. He had atherosclerotic cardiovascular disease, some sleep apnea. And then in his CBC, he had anemia, a mild anemia of hemoglobin of 10.5, mild microcytosis, normal white blood cell and platelet counts. There was no iron or other deficiency. And surely enough, bone marrow was done. On the aspirate, it was and biopsy, actually, it was hypercellular with cellularity around 80%. There was dyserythropoiesis, no excess of blast, but a significant amount of ring sideroblast was noted. His karyotype was remarkable for 20Q minus abnormality, and NGS panel demonstrated several abnormalities, actually, including RUNX1, TET2, DNMT3A, and also, not surprisingly, SF3B1 mutation with variant allele frequency of above 40%. So the diagnosis of MDS RA-RS, which was previously the term, was done, and according to, it was low risk according to IPSS-R and IPSS-M, and it was decided to follow him up. In the end of 2022, he became symptomatic. His hemoglobin dropped as low as 6 grams per deciliter. He maintained normal white blood cell and platelet count. He had some anginal symptoms. He sustained a significant COVID-19 episode. His function deteriorated. Repeat bone marrow angiogenesis actually yielded the same picture, although his cellularity went up to 100%. Understandably, he became a transfusion dependent, actually heavily transfusion dependent, with 2 to 3 units of blood per week. Unfortunately, though, ESAs failed even at high doses, both with recombinant erythropoietin and darbepoetin. And then luspatercept was actually considered, but unfortunately, the patient had no access to the medication due to reimbursement issues. Imetelstat was not an option. So other modalities were considered, which including the transplant and hypomethylating agents. Fortunately, in the middle of 2023, the patient did get an access for luspatercept, and it was approved, and he immediately started the medication. And as we say, one picture is worth 1,000 words. It's a dramatic response to this medication, to luspatercept, with increase in hemoglobin up to 12 or even 12.5%, and even at some point, the dose had to be reduced. So currently, the patient is doing well. He's very mildly symptomatic. His hemoglobin is maintained at 11.5 grams per deciliter. He's still low risk, and we hope for him that he will continue to be in a good condition in the next couple of years, but we have to think, of course, what would be the next step when he progresses. So the second case is slightly different. This is a 78-year-old patient. He's had asymptomatic anemia for quite some time, and then there was some progression. He became mildly symptomatic, or very mildly symptomatic, with hemoglobin dropped to 8.6, with macrocytosis, normal white blood cell and platelet count. Bone marrow was done. It was hypercellular, with both erythroid and megakaryocytic dysplasia, but no ring sideroblasts in this case. There was no excess of blasts, normal karyotype, both by G-banding and FISH MDS panel, and MGS yielded actually in a single DNA T3A mutation. So this is a list of questions that we offer to the panel. The first, what are the indications for transplant in low-risk MDS patients? Is there any significance for very high cellularity, like 100%? Does SF3B1 mutation always have a fairly good prognosis? Maybe when it comes as a co-mutation, it's somewhat different. What is the first-line treatment in symptomatic transfusion-dependent patients? Is it still ESAs, or maybe we should move to luspatercept or imetelstat and so on, whether in both in SF3B1 mutated or unmutated or RS negative patients. When luspatercept fails, like it could happen in the first case, what would be the next step? Either imetelstat, HMA, transplant, and finally, what is the hemoglobin threshold for anemia treatment, mainly in non-transfusion dependent patients? As the first line, should we stick to the traditional ESAs, or maybe we should move on also to newer novel therapies? And lastly, actually, is there any significance to variant allele frequency of different mutations, whether it could have any implementations to selecting therapy? Thank you.
Thank you. And now open to debate. Rena, start.
Okay. So first of all, I'm going to just tackle how I would have treated these two patients based on the evidence. I'm going to make the assumption that the EPO levels were below 500 for both patients. So they were not provided, but I'm assuming the fact that ESAs were tried and then luspatercept was tried, and the evidence is only in patients with an EPO level less than 500. So for the patient with the SF3 beta-1 mutation, if I didn't live in Canada and I lived in the wealthy United States, I would be using luspatercept as frontline therapy for that patient based on the results of the COMMAND study that incontrovertibly show that these subgroups of patients have higher erythroid response rates and durability with luspatercept. For the second patient that is non-SF3 beta-1 mutated, again, I would want to know what the EPO level is. If the EPO level was over 200, I would think that they're very less likely to respond to ESA, but it would not still be unreasonable to try an ESA first. It's more economical, knowing that their response rate's going to be lower based on the results of commands. and then followed by luspatercept if again in the United States it was available, not in Canada because it's only for patients with ring sideroblasts. So definitely the EPO level is needed and whether or not they're SF3 beta 1 mutated. Of course, the frequency of their transfusions, the more transfusion dependent, the lower the rates of response to both, and in particular to ESAs.
Yes, I fully agree with Rena. This is the same we do in Europe, or at least in the Dutch community, like you say. The question also is now the indication in that 67 years old first patient with potentially now a refractory of less responsive to luspatercept, and when to go to a transplant in the lower risk MDS. That's also one of the main questions. And in generally, what I think is that transfusion dependency for young patients is one of the indications. However, if you have an indolent disease, like the MDS SF3B1 mutations as a single mutation, you might still argue against a transplant, especially in this 67 years old man with a lot of comorbidities. However, we don't know, but that could be an argument not to transplant. And if then refractory on luspatercept or lose response, then go to a clinical trial, if there is a trial, or to imetelstat thereafter. That could be an option. The question that SF3B1, in the first case, there was a RUNX1 mutation. So actually, it is not defining MDS with an isolated SF3B1. That might also be different. Maybe you can comment others on the role of the RUNX1 in that specific entity, and then argue that maybe a transplant is better than to wait.
Yeah, I think you do have to consider risk, keeping those mutations in mind. But it sounds like your patient did have a really robust response and actually still had hemoglobins in the 11 gram per deciliter range. Yeah. So any symptoms that they have are probably not due to their anemia. Yeah. I would ride the luspatercept for as long as I possibly could in that patient before considering options like transplantation.
If at all.
Yeah, exactly. So one of the issues with nomenclature is that we call these patients lower risk based on how they would score on the IPSSM, for example. But if they've exhausted all the therapies that are available to them and they remain transfusion dependent, then they're clearly not low-risk patients anymore, even if they don't have excess blasts or complex karyotypes. So for me, that exhaustion of therapies in patients who still need some sort of treatment to address their symptomatology is an indication for transplantation. Normally, I would try maybe some higher risk therapies before getting to that point, like a shorter intensity schedule, a hypomethylating agent, for example. But I don't think we should call those lower risk anymore.
Hypermethylation in lower risk as a second or third line? Is that pre-transplant?
To achieve transfusion independence.
And then go to a transplant.
If they become transfusion dependent again.
Yeah, MD Anderson has done a study where they did a reduced intensity treatment, 5 days of azacitidine or 3 days of decitabine, that has very similar response rates to what we see in the high-risk population with perhaps less toxicity. And it does help patients respond and no longer be transfusion dependent. So it's something I would consider in a lower-risk patient.
May I comment? The other indication might be that there is a more progressive granulopenia or a thrombocytopenia, which is also a sign of a change in the biology of the disease, which might go to your argument to go to a transplant if the transplant comorbidity scores or other scores you mentioned might fit with a good outcome, independent of the conditioning.
Can I ask you something, all the three of you? How much is IPSSM determining your choice? So if you have a low-risk IPSSR who has an IPSSM high or moderate high, what is your approach? Which one would you consider?
Yes, so that's actually increased the number of referrals that I make for transplants because of, again, a recent Markov model that showed that moderate high, and very high IPSSM patients seem to have maximized life expectancy if you transplant early rather than late.
Young patients.
Younger patients.
Younger. Yeah. The one above 60
low risk.
Do not seem to be to get such a big advantage from an early transplant.
I think actually in the younger patients, even the moderate low seem to benefit from transplant as well in that study. So it's even, that's for older patients, moderate, high, high, and very high, and for younger patients, moderate, low, and higher benefit. So no question, it was very important to calculate the IPSSM, which I did for those two patients, and both were kind of on the lower risk scores, so I hadn't recommended it. But yes, I definitely am referring more patients for transplant based on the IPSSM. And we know that 47% are upstaged by the IPSSM, and of those, or have a change in their classification, of which 75% are upstaged.
I think that's the major impact of the IPSSM, is identifying those patients that may benefit from transplantation. I don't use it in order to justify using higher risk therapy in a patient who wouldn't otherwise meet criteria for that. I think our decision to use a hypomethylating agent really depends on the clinical picture and not necessarily the score that you see.
I agree.
I agree. And note the behavior of a MDS, low risk MDS, might be transforming to an aggressive disease, but on the other hand, the bone marrow failure compartment, and that is the balance you have to do. Not to, then the leukemic burden is not a question, but then the clinics, the bone marrow failure component, and especially in those IPSS molecular lower issues, there's 1/3 never progress, but.
I agree, but it is sometimes difficult to choose the more aggressive way. If you have a patient who has moderate anemia or moderate cytopenias, but high IPSSM risk. So then it's very difficult, but we are starting now to see this sort of patients, and we should really try to see prospectively what is the best. So the model is quite clear, but the implementation in clinics is still to come, I think.
And I think, addressing one of these questions is, what do we do about increasing variant allele frequency or the emergence of new clones? That may also help, determine whether or not you're going to refer to a transplant sooner rather than later, because it seems that the biology of the disease is evolving and that they may be closer to developing acute leukemia than the other patient whose VAF is staying the same or declining, or the VAF is very small. And Arjan, you mentioned something about the RUNX1 and co-mutations. And so, in preparing for this, I came across a lovely study that I think Valeria is a co-author on, in this real-world study of a combination of the largest cohort of luspatercept-treated patients from the Moffitt and FISM, and they looked at the of response rate of luspatercept in the real world. And they actually kind of arrived at this sort of SF3 beta 1 alpha versus beta, which is the alpha, the beta, which has co-mutations and some unfavorable mutations like BCOR, BCOR-L1, NRAS, RUNX1, which our patient does, had an SRSF2. They had lower response rate to luspatercept than SF3 beta 1 alpha. Now, would have, I'm going to ask Valeria, would that stop you from trying luspatercept in that patient population? Or would you think, okay, they have a lower chance of response?
Well, not really, because we do not have other options for this kind of patients. So, and again, response was not zero.
Yes.
Response was less than the one we see for SF3B1 alpha. And anyway, even for the patients who had response, there was finally an advantage in overall survival. Not as much as we see in the real responders, but still.
But does it argue to go to a more intensive treatment regimen earlier if you have the co-mutations? Although your response to luspatercept might be less. You first try luspatercept, yes, and then might differ to think about the next step, the transplant. That is the other question.
Although it's hard for me to get, I sometimes will still try lenalidomide in a few patients with non-deletion 5q MDS. I've had patients who've responded 2.5 years on lenalidomide. It's hard to get, but there may be, that's another agent to consider in somebody who remains low risk without any adverse high risk mutations, or who is clearly not transplant eligible. So there's the HMAs, and then there's also lenalidomide.
See, all these drugs are off-label, but they still showed some of course, some activity. So we should, again, go back and see which are the patients who respond.
Yes, we have it now in our guidelines. It was already in the NCCN guidelines for the use of LEN in the non-DEL 5Q, and in our community also we now point it out based on evidence on the trials to also put it in for the non-DEL 5Q, etc.
Yeah, but before luspatercept here in the US, in the Medicare survey, the lenalidomide was used more in off-label for non-DEL 5Q than DEL 5Q. So it is, you know, some patients do respond for a very long time.
And do you combine it with an ESA, or do you give it by itself?
Well, the French group combined it with ESAs and had very good results. We evaluated as a single drug, and there was, in some cases, a very good response. Less than 30% overall in the ITT, and 42% response, TI response in the patients who had serum EPO lower than 100 units.
And actually,
so you see, you may extract the patients who are responsive.
Within one of the HOVON trials, we did also ESA-LEN, and it does not help any. It does not add additional value.
Okay.
But there were also some signals of response, higher response for molecular subgroup. And this is something we should look more and more, because we don't know whether we can select patients for specific therapies on the basis of not target therapy, but just some therapies.
To comment on that, in the SLW1 mutated ones, before the luspatercept era, they do not respond on the combination ESA-LEN. This is interesting, so you have more new combinations in the non-DEL 5Q setting.
And I think there was also a lower rate of response in non-deletion 5Q to lenalidomide if you had an ASXL1 mutation. It wasn't statistically significant, but there's definitely a signal. I think you showed this, Valeria, that they don't do very well with lenalidomide.
DNMT3A was the best. Yeah, also for overall survival.
That stresses the former discussions we have had with Robert in the diagnostic, that the profiling predicts to some extent also the chance of response to the newer drugs, and therefore.
That's right. Yeah, that's right. We're going to be hopefully using some of these genetics to help decide, should we choose this one over this one based on what mutations they harbor. I'd like to ask my colleagues about the initiation of therapies in anemic patients who aren't transfusion dependent. That's one of the questions. So, you know, my practice is at all costs to try to avoid transfusion dependence, because we know it correlates with bad survival and leads to iron overload and the complications thereof. That may in itself help. The iron overload may contribute to the ineffective hematopoiesis. So my practice is to avoid transfusion dependence like the plague and initiate my therapies early. Is that your practice? And have there been any kind of financial implications or regulatory implications for funding for non-TD patients?
Yeah, I mean, I practice in the US, so we don't even have to think about those things, right? But that is definitely my approach as well. I think now we are starting to see some evidence to suggest that the phase 3 trials of ESAs that were conducted in Europe actually included patients that were not transfusion dependent, and they seem to have similar, if not better benefit than patients who were more deeply transfusion dependent. In the Sintra study we have with lenalidomide also suggests that might be the case with that drug. But even with luspatercept, I tend to use it when patients are approaching that transfusion dependence threshold and not waiting until they get there, because they're symptomatic before they get transfusion dependent.
The only critical point is if you have a disease which is not per se dramatic in the first 3 to 5 years, that you use a drug too early, although preventing transfusion dependency, I agree with all the consequences. However, the data should grow whether or not we select clones by lenalidomide, for instance. That is, although in a Sintra study it was not shown, I think, but too early might also escape your treatment for long-term treatments or clonal evolution, and thereby that might. Although in the ifosidenib studies, we don't see any changes in FAF at all, although they respond. So it's
and higher, as you pointed out, higher rates of cytogenetic remission, like 90% in the Sintra-Rev study, whereas it's lower in the 003 and 004 studies.
Which could actually reduce the rate of clonal evolution.
Right.
Yeah.
Right.
So.
Okay. Thank you very much. It was a very fruitful debate and discussion. Okay, now we have the second debate, and it's really something I see looking up at the future. Should individuals with an MDS germline mutation be proactively treated? This is a very new problem as we measure and we look for germline mutations. So yes, Carmelo, Gurnari, welcome. And let us know what you think about it and which kind of therapy you are thinking of.
So thank you very much for the kind invitation, and welcome everybody. And I also thank for the organizer of this fantastic symposium. I have no disclosure related to this talk, if not that I come from the crib where political debates were first born, the ancient Rome. So this is a masterpiece by Macari, which is in our Senate in Italy, and is the incipit of a famous speech by Cicero against Catilina. So I just want to say, Rafael, do watch out. So jokes aside, in the last decade, the recent application of a technique able to screen the whole genome unveiled germline variants in several myeloid disorders, emphasizing how also adults may carry such predisposing traits. Their precise recognition has important clinical repercussions for correct patient management, genetic counseling, and ultimately for transplant strategies in patients that are eligible for this procedure. In our first seminal paper, Jarek Maciejewski identified a familiar MDS AML syndrome characterized by long latency and germline mutation in the gene coding for the dead box helicase DDX41 located on the chromosome 5. The precise estimation of the etiologic fraction of hereditary gene alteration in the pathogenesis of MDS in adults is hampered by difficulties deriving from differences in disease latency and phenotypes, reduced penetrance, and heterogeneous application of genetic testing, absent or incomplete family history, and issues of competing mortality. However, we can estimate that about 5 to 10% of all comers MDS can carry inherited traits. If focusing on DDX41, germline variants were found very commonly in a population-based study leveraging almost 500,000 individuals from the UK Biobank. Let's now get into practice. Here I present you a 75-year-old man who was referred to our clinic with the CBC you see on the slide. Bone marrow showed hypocellular MDS, ding, ding, ding for DDX41, with 11% blast, normal cytogenetics, and our NGS with a germline-prone gene card revealed only the classical constellation of a germline truncating hit plus the 525 somatic alteration, which is a typical configuration for DDX41. The germline mutation was obviously confirmed in a non-myeloid-derived tissue, and we then start pondering over the risk of this patient in order to best decide the treatment option. And here comes the issue. However, as you can see, when applying the various MDS risk score, we have a very heterogeneous and contradictory risk assessment with difference of survival spanning years. In a recent global effort, we demonstrated that the current prognostic tools are not able to capture invariant biologic features for outcome prediction, differentiated DDX41 mutant MDS as a distinct nosologic subentity, defying the accuracy of both IPSSR and IPSSM, as you can see in the slide. Therefore, we explore whether DDX41 specific mutational configuration may have a role in driving specific MDS outcomes, and we assign the greatest prognostic impact to the R525 somatic mutation and the germline truncating hits. The former impacted most survival outcomes, whereas the latter independently predicted the leukemia evolution. Such features had synergistic effects and were included in DDX41 specific multivariable outcome models, which alleviated the shortcomings of the tools that we normally use in a daily practice, like IPSS-R and M. Now, let's apply the DDX41 specific risk score to our patient. You see we have an overall survival of 45% at 4 years, but a leukemia evolution of 67%. Definitely not aligning with the risk of an IPSSM moderate low. So now, what does the presence of a germline trait add to treatment indication in this very patient? So first of all, it helps with risk assessment when compared to the currently used tools, alarming on its very high risk of leukemia evolution and therefore on the potential option to give a disease-modifying treatment. DDX41 MDS showed good response to azacitidine, and this is demonstrated in multiple studies. And indeed, the drug seems to abrogate the detrimental effect on prognosis of both the germline truncating hits and the somatic 525H mutation, which are both features present in our patient. Now, what did we do? He was 75, not really willing to get allografted, so we started azacitidine, and is now at his 20th cycle and doing well with a near normal CBC and good quality of life. Now, let's see this other DDX41 scenario, which we discussed together with Dr. Chirpek and Mittelman, and we thought it was a very good fit for this debate. It is the case of a 69-year-old man with a maternally inherited DDX41 mutation whose disastrous pedigree you see in the slide. The patient was particularly invested in surveillance and aggressive management to try to avoid the fate of his mother and family members. Now, I want to take this as an opportunity to stress how important it is to consider the psychological and ethical burden when we discuss and open the Pandora box of germline predisposition in MDS patient and with their family. Let's see a timeline of event for this patient. He underwent surveillance bone marrow for evidence of MDS progression, and only at the end of last year, in 2024, where he was 69, he showed sign of progression with also acquisition of the famous R525H mutation. However, at that time, his IPSSM was very low, with only 2% of leukemia evolution risk at 2 years versus the 38% assigned by this new DDX41 tool that I just presented. Of course, also in this case, the question was what to do, given the MDS progression with the acquisition of the 525H. And please remember that the paper regarding the DDX41 tool is available as of like 2 days ago, because we concocted with leukemia the release of the paper during this talk at ASH. So all this reasoning was done by Dr. Chirpek in an agnostic way. A 3 months follow-up bone marrow showed already progression to MDS with increased blasts consistent with rapid progression. So the patient was offered transplant, which in these cases need to evaluate the potential inherited trait segregating in a donor if we use a relative, and adjustment of conditioning regimen for DDX41. Some literature evidence, which must be confirmed, suggests the potential role of PTCI to abate the greater risk of the GVHD. The patient underwent 2 cycles of azacitidine while searching for a donor, which was identified in a match unrelated donor, and allografted with a flucide TBI with post-transplant cyclophosphamide as GVHD prophylaxis, and was discharged after 2 weeks, did not require any transfusion during the ADSA or pre-transplant course, and is currently riding 30 miles a day his bike. So taken together, I think that these 2 cases teach us a lot regarding how clinically informative is to know that a patient has MDS with germline mutation, with regards especially to his treatment strategy. I chose DDX41 as it is the most frequent trait you all have for sure see at least 1 or 2 patient because, as I said, it's like more or less 5 to 10% the presence of these traits and 4% overall specific for DDX41. And DDX41 has a distinct pathobiology, which we now understand pretty well, to the point that we can derive a proper risk assessment and decide the best treatment option for our patients. And with this, I'm done, and I thank you all for the attention, and I'm happy to take any question later with my opponent.
And now Dr. Bejar comes back to enlighten us on the no proactive treatment. Raf.
So thank you for the invitation to be here, and thank you for making an excellent introduction to the topic. I'll answer the contrary question about should individuals with an MDS germline mutation be proactively treated. These are my disclosures. And in the spirit of these debates, I've decided to reframe the question so it makes it easier for me to answer. Instead of asking specifically what was asked, I'll change it a little bit and say, should all individuals with an MDS germline mutation be proactively stem cell transplanted before they develop MDS? That's really the treatment that might have a defining role in curing the disease for these individuals. And we should, of course, never deal in absolutes and say that we should never do something. Always and never are two words you should always and never remember to use. And medicine is a science of uncertainty and probability, which will be where we end up with our answer, where we have to take into account what we don't know and what we think is likely to happen. So let me start with a case, a patient of mine, a 42-year-old woman with a history of cyclic neutropenia, diagnosed in her mid-teens, a bit late, and very little past medical history other than erythema nodosum. She was recently hospitalized with neutropenic fever and pneumonia and has now fully recovered. She's asymptomatic and doesn't really have any other concerning developmental issues. But she does have an important family history. Her father, who at age 50 developed AML, actually died of a fungal pneumonia as he was being prepared for stem cell transplantation, and this has impacted the patient very significantly. Her counts at the time were moderate. She had a white count of 2.0 with an ANC of 0.9, hemoglobin of 10.3, and platelets of 166. And of course, we did a bone marrow biopsy, found that it was hypocellular with 1 to 2% marrow blasts, and had some dysplasia, but not enough to be definitive of MDS. Did have evidence of clonality, however, had a trisomy 8 and 2 of 10-20 metaphases, and had an NGS panel that was very concerning. She had a GATA2 mutation. In fact, she had 2 variants that were called on the panel. They were consistent with the germline configuration, and a STAT5B mutation that looked perhaps like it might be more of a somatic event. So we'll come back to that case to help highlight why we think about how penetrance matters for these patients. Because in order to decide what to do with this patient, you have to get a sense of what her risk is of developing a more serious disorder than she currently has. And one of the challenges with estimating penetrance is that when we first identify these cancer predisposition genes, we tend to find them in patients who have very overt phenotypes or very strong family histories, like the one that Dr. Gurnari just showed for his DDX41 patient. And these are the variants that I think are more likely to cause disease when you look at them in a general population. But once you go and look in a general population, you may find that these variants occur in patients who never develop disease. In other words, the estimated prevalence from doing a genomic ascertainment is much lower than it would be if you did a phenotypic ascertainment, taking, for example, probands that are relatives of affected family members. And the reason for this may be due to differences in genetic background or environmental exposures, or due to hypomorphic variants that tend to show up less often in people with frank disease. And there is another problem, is that many of the variants that you find are variants of undetermined significance, as I'll show you we have in our example patient as well. So DDX41, I think, is a great example. It had an initial prevalence or penetrance, I would say, of about 40 to 50%. And this came from looking at relatives of affected probands. And one of the challenges with this particular variant is that it has a late disease onset, so there were other competing risks, including death. Now, we've gone back and done population screening, as Dr. Gurnari alluded to, that has shown a much lower estimated penetrance, perhaps even as low as 10% in younger individuals. And by definition, we find more VUS in this patient population. And there are a whole bunch of other factors that ultimately determine the potential penetrance of a gene in an individual. And ultimately, you have to identify the individual's risk of that progression and not simply apply a blanket probability in order to make a decision as profound as whether or not you transplant a potentially asymptomatic patient. The bottom line is that we don't recommend stem cell transplantation for asymptomatic people who have germline DDX41 variants at any age, even if they have a strong family history of MDS or AML with moderate cytopenias. Now, looking back at GATA2 as it relates to our patient, these are slides that were lent to me by Marcin Wolodarski, who gave an excellent talk at the ESH meeting back in October, where he has really looked very closely to understand what these mutations mean in individuals in the long term. And he's identified that patients can manifest with some elements of marrow insufficiency, cytopenias, hypocellular marrows, for example, but no dysplasia. Or patients may have a more premalignant phenotype with some degree of dysplasia, or even perhaps clonal markers like trisomy 8 seen in our patient. And of course, there are patients who present with evidence of overt malignancy, can be defined by the presence of monosomy 7 or high-risk mutations, excess blasts, and so on. And the question that he had is, what is the actual prevalence of these 3 different states during the course of treatment or the course of management for a patient with a GATA2 mutation? And are there associations between mutations and the ultimate risk of developing disease? He looked at over 930 cases at his database at St. Jude's and identified the different phenotypic groups that these patients might fall into, paying special attention to those patients that either had malignant progression or that had this kind of pre-malignant progression like we see in our patient. The important thing is that he found that patients were symptomatic at a tremendous amount of the time. About 93% of the time, you could identify 1 or more abnormalities that were typically associated with GATA2 mutations in the germline configuration. And 80% of these individuals developed some sort of myeloid disorder. What was important is how variable this was depending on the type of mutation that was identified. The age of onset was also different, that 50% of cases tended to present before age 20, so very different than we see in our patient example, and that it was very rare to see events in very young patients. So it did identify a window of screening that might be more relevant for patients with this particular disorder. And one other finding that they had is that there were certain alleles that were much more predisposed to causing disease than others, and they were hypomorphic alleles. Null mutations tended to be the worst. They had the highest risk of malignant progression, and it tended to occur earlier. But intron 4 mutations in GATA2 had a much lower risk of myeloid malignancy development and perhaps lower penetrance overall. So it's not just what gene is mutated and in whom, but in what configuration and what mutations you actually see. And if we go back to our case and we apply what Marcin has taught us, we can see how to use this. And they have this great resource at the GATA2 database where you can look up individual SNPs to see how often, or individual variants to see how often they occur in patients. And we learned from that that the G450 SNP that our patient had is probably just a benign variant. But the R39AQ variant was actually seen in several individuals out of 4 families, including 6 that were asymptomatic and had a wide range of ages, 2 that had very few symptoms, only infections with no other findings. But 3 of them did go on to develop MDS, including one with trisomy 8 like our patient, and one that went on to develop AML and stem cell transplantation. Interestingly, the 62-year-old woman in this example was asymptomatic, whereas the MDS cases tended to be younger, 19, 25, and 36. So based on this information, the recommendation for this patient at diagnosis was really to proceed with stem cell transplantation. We felt that she had a high risk of malignant progression, perhaps lower than simply having a GATA2 mutation overall might imply based on the type of mutation that she had, but that the risk was very substantial. Now, is there a way to help us understand when we might do an intervention like a stem cell transplantation? Obviously, you shouldn't do it in very, very young children simply because they have a GATA2 mutation. But if you have an older individual like this, is there a way to try to predict when that timing should be initiated? And we know that these individuals tend to have a high frequency of co-mutations or other somatic events, monosomy 7 being by far the most common. But there are frequent other events that are not necessarily disease-defining, like trisomy 8, for example, or mutations in genes like ASXL1 or SETB2B1 and so on. One of the interesting things is that different ages tend to have different forms of clonal evolution. So patients, for example, that make it into their 20s or beyond tend to have a different pattern of somatic clonal evolution. They tend to have more trisomy 8, for example, and more STAG2 mutations. And perhaps these patients actually have a lower penetrance of disease, despite the fact that they have clonal hematopoiesis. And Marcin was wondering if perhaps there was some element of somatic rescue in these individuals like we see with other disorders. Whereas younger individuals with GATA2 mutations that had monosomy 7 or SETBP1 tended to have a higher risk of malignant progression. But for other germline disorders, like RUNX1 mutations, for example, we also see that in family members of affected probands, that clonal hematopoiesis is remarkably common, and including in genes that we typically associate with higher risk, like the DNMT3A R882H. Importantly, if we look at the bone marrow of these individuals, we often see abnormalities that really resemble the morphologic criteria used to define MDS. So we see dysplasia, particularly in the megakaryocytic lineage, and we have to be very careful not to combine this moderate dysplasia with these somatic mutations and call someone as having a diagnosis of MDS prematurely, because it might lead to treatment that is really not necessary at that time, including consideration for transplant earlier than we might otherwise think. Ultimately, it's going to come down to a risk versus benefit decision. And can we apply tools that we have today to help us understand what that risk is and to help us understand what that potential benefit of stem cell transplantation might be? And as we've shown, we do have these excellent tools that help us do that with patients who have de novo MDS, where we can consider age, IPSSM risk score, and determine which patients might have the best life expectancy with or without transplantation. However, as Dr. Gurnari pointed out, these tools don't necessarily apply to all patients with germline mutations, and DDX41 cases in particular, I think, are the most challenging, where the IPSSM really underestimates risk, yet our therapeutic approaches may actually be better in those individuals when we consider drugs like azacitidine. And ultimately, given the risks of stem cell transplantation that may be higher in this DDX41 population, this decision to transplant folks simply because you can or they have this mutation isn't necessarily as clear-cut as it might be. So if we go back to the case that I presented at the beginning, I actually met her in 2019. And at that time, she adamantly refused a transplant evaluation because of the experience that she had seen her father go through. I did convince her to finally see a transplanter a couple years later. At that point, we repeated a bone marrow biopsy, and she had clonal expansion, but no evidence of clonal evolution, and her blood counts were much the same as they were when I first met her. In fact, even last year, her blood counts are much the same as when I first met her, with moderate cytopenias throughout. And she continues to do well, and I always wonder, had she accepted my advice to undergo a stem cell transplantation in 2019, might she have had the quality of life that she's had for the last 6 years, where she's been able to raise her children, hold down her job, volunteer at her school, and so on. And ultimately, the bottom line is that no, not all individuals with MDS germline mutations should be preemptively transplanted if they can be. It's still a risk versus benefit decision based on the best risk estimates and tools that we have. But we have to understand that this risk varies not only by gene, but by the individual variant in that gene, by other factors like sex, age, and family history, and type of clonal evolution, and more. And we're still learning about which of these factors are most important and how to apply them to individual patients. And we need to learn more about the factors that affect disease penetrance at that individual patient level. So I think the tool that Dr. Gurnari was just speaking about was really wonderful to have that so we can apply it more individually for patients with particular mutations. And of course, patient preference will still be highly important in making these decisions. So thank you, and I welcome the discussion.
Thank you. So any quick comment?
This is just for show, I think, because we have it. So I think, Rafael, you touched like a very important point, which is having in your team an expert in molecular biology to interpret carefully the mutation, especially those of germline origin, in our patient. Because this is like, for instance, as you pointed out, important for GATA2, this is important for DDX41. There's a lot of patients who are classified with VUS, and because of like the criteria, the ACMG criteria, which cannot be upgraded to the likely pathogenic or pathogenic one, but they still have indeed an MDS with germline predisposition. And there are some movement in the field, also specifically to curate and filter variants in the germline setting. There's like a nice study that shows, for instance, that even if you have a DDX41 VUS, but if you acquire the 525, that is like an criterion to increment this VUS to a likely pathogenic. So I think that is really something important. We need to all work together.
Yeah, I wonder if we need to change our disease definitions a little bit and say that perhaps patients who have these biallelic DDX41 mutations shouldn't be considered to have CCUS if they don't meet diagnostic criteria. They should be really falling under the umbrella of having a myeloid malignancy and be treated as such.
Totally in agreement, and I think the WHO next year should address this.
Preview.
Okay, thank you very much. It was very interesting.
Thank you.
Thank you.
We are moving on. Can I have the first slide of the clinical review and discussion on current paradigms of drug developments? Yes, Houston, we have a problem. Over the last 25 years, only 7 drugs have been approved. Only 7 drugs. And there is an estimate, also reported by the Urlich-Germing-Düsseldorf group and others, that in about more than half of the patients, especially those with lower risk, after 2-3 years, we don't have any effective agent to offer. And this is in contrast with other myeloid or hematological neoplasms, as you can see here in the slide. For lymphoma, over this time, 17 drugs, myeloma, 15, AML, 12, CLL, 9, MDS, only 7. So we wondered what are the reasons, and I asked 2 top world experts to help me and to share their thoughts about it and to try to provide us explanations. Valeria Santini from Florence, who is here with me as a co-chair, will talk mainly about higher risk patients, and she will explain why all these trials with high risk patients failed. I will follow, focusing on lower risk and several other aspects of general development of drugs. And finally, Dr. David Steensma, who is well known as an MDS expert, but now as a chief medical officer in Ajax Therapeutics, will tell us the pharma's point of view. Valeria, please.
Thank you very much, Moshe. I will not explain. I will try to understand what happened and why. If I had the possibility to know why, maybe I would be a colleague of David or just having great results. So thank you, anyone. These are my disclosures. And also, all the drugs I will present in my lecture, in my talk, are not approved because of the failure. So these are not approved drugs, and with the exception of azacitidine. Now, I drew this design some months ago, maybe more than a year ago, and I hoped that some of the drugs that are here in red would have become available and would have been successful in treating high-risk MDS. But as you see in the square, unfortunately, all the attempt of the combination of HMA with other agents were unsuccessful. And this is a very sad slide because I actually had it as my educational at ASH in 2012. And I am afraid that apart from some modification for the age of transplant-eligible patients, this is still unfortunately valid. Of course, you may say that we use IPSS-R and that we use IPSS-M, but the picture doesn't change much. So investigational agents, question mark. What about the standard of care we have for high risk, which is azacitidine or decitabine? You see these are real-world data that show you that when we treat patients in our centers who are not selected and who may have some comorbidity, the median survival in Italy and in the Netherlands is around in between 16 and 18 months. And this is not really a great achievement, but still shows you that we may prolong the expectant life. But then I show you a very depressing slide that is showing you that the overall survival in TP53 mutated patients, monoallelic versus biallelic, it's really bad. And the biallelic patients have a very short expectancy of survival, independent of all the therapy you can try. They may have a response, but the response is short, and therefore we do not have a real treatment. That's the worst we can have for high-risk MDS patients. And we may discuss also with AML. But then we had the hope to have a drug, APR-246, that was reactivating the function of TP53, because TP53 is mainly mutated as a loss of function. So there were 2 studies, head-to-head, phase 2, that showed indeed a very good response to this drug in patients with this mutation. And here comes the phase 3 trial. The phase 3 trial did not show overall response rate or overall survival difference among the patients treated with the azacitidine only or the combination with a prenatal POPT. So what next? So the combined results of these 2 studies have been published recently. And with a longer follow-up, we do not have any publication for the phase 3 in my knowledge, but what is the main observation here? Here we had more patients with biallelic TP53 than patients with monoallelic TP53, and this could have been the reason why these patients were so less responsive, and probably the drug was not enough to overcome the biallelic defect. So why these patients failed to show any response? Are these too high risk? Is transplant for this patient, with all the caveat, the only solution? Or should we look at this kind of therapy for TP53 mutated patients only as a bridge to transplant, because the responses don't last? These are actually open questions. And then we had the adventure with pevonedistat, is an inhibition of NED-dilation combined with azacitidine. Phase 2 data, very, very promising. And then you go to the phase 3 data, showing, comparing the combination of pevonedistat to and azacitidine to azacitidine alone. And the same was true for other studies. They combined higher risk MDS and CMML. And the stratification was there, but the population was sort of heterogeneous. And you see that the primary endpoint was event-free survival. What happened was that actually the response rate and the overall response rate, as you may see, was not really favoring the combination. And the event-free survival and overall survival, again, didn't show a significant difference. So no primary endpoint was met, although it was clear in a post-hoc analysis that if you prolong, the patients who had more cycles, so more than 6 cycles, may indeed show some advantage in overall survival from the combinations. So why is that? Lack of hematological response because the treatment was not long enough, or we selected the patients who anyhow had a lower risk in some sense. Do we need longer drug exposures? But then we anyway select the patients who somehow respond and survive. And then again, so another failure. We expected to have a completely new mechanism of action, anti-CD47 antibody. The magrolimab study was comparing the combination with azacitidine to the placebo plus azacitidine. And the idea was that this kind of reactivation of macrophage activity would overcome even the difference in mutations and the risk based on mutation. But unfortunately, when you look at the outcome, there was not an improvement in response. And unfortunately, the overall survival, as you may see, was really not favoring the combination, especially for the high mortality in the very first period of treatment. And as you see here, this was really probably the most important finding, that there was such a high toxicity in terms of on-target anemia that was in the beginning not really mitigated that could have been impacting on the result. So the study was closed for futility. There was probably an under-evaluation of this toxicity. There was a bias in the enrollment of high-risk patients. I hope we will see the results published to understand more in detail what happened in this case as well. Okay, then we change gear again. Another mechanism of action, stimulus MDS2, was a study comparing the combination of sabatolimab plus azacitidine to placebo azacitidine. And sabatolimab is an anti-TIM3 antibody that reacts with exhausted T cells, but also with leukemic stem cells. And again, patients with CMML, high risk, and higher risk MDS. And the primary endpoint was overall survival. You see the responses were, in fact, favoring the combination somehow, but the overall survival primary endpoint, again, was not met, even if you consider MDS only. So the problem I'm showing you is that almost all the study in high-risk MDS combined high-risk MDS and high-risk CMML, which are not exactly the same kind of disease and may, in fact, lower the power, the strength of the study. But nevertheless, these are the data for the MDS only, so no difference in CR nor in overall survival. Is this a lack of proper selection? So the biomarker, the immunological pattern and characteristics were not considered enough to select patients. This is something we should always ask for all the studies I mentioned to you. What was the background biological basis for these treatments? But what we saw in the sabatolimab plus azacitidine post-hoc analysis was that women, in fact, had a statistically significantly longer overall survival. So sex in this case, and most probably the immunological asset and the T cell exhaustion was very important. And so a sex-based approach could also drive some new ideas and some new results. Finally, this is the result of an interesting study combining azacitidine with tamibarotene as a RAR alpha inhibitor. And what was the purpose of this study? To see whether patients who overexpressed RAR alpha, patients with high-risk MDS, could take advantage of the combination. And here, the primary endpoint is CR, is no longer overall survival. So the idea is that you sort of reactivate maturation gene expression by combining tamibarotene with azacitidine. But as you see here, there was, in fact, an improvement in CR, but actually the study was not significant. So this study as well was failing, but we learned from this study and the other a lot, because we learned that we have really to organize our studies in a different way. And probably there was, at the basis of this failure, a lack of validation of the biomarker, the RAR alpha overexpression in high-risk MDS. And what about the patients who had this overexpression? What was the exact role in high-risk biology? So the Verona, you will hear more about Dr. Garcia-Manero tomorrow, but the expectancy for this last study was very, very high. So we were anxiously waiting for the results, and the phase 3 Verona study combining venetoclax to azacitidine and comparing to azacitidine alone, unfortunately was not successful, meaning and stressing the point that AML and MDS are not the same disease and are not a continuum over. So the endpoint here was overall survival. You see, you may note that in the majority of the studies I showed you, the TP53 percentage is pretty high. Here, a quarter of patients had TP53 mutation. And these were, of course, patients who had different percentage of blast and different IPSSR risk. No difference in overall survival when you take the entire population in intermediate and higher risk MDS patients. And there were no new safety signals, so no excessive toxicity, but again, you'll hear more about the Verona trial in this meeting. These were the results shown at the SOHO meeting last September. Higher marrow CR rates for the combination versus the azacitidine alone. But again, is this important in the overall result? Probably, as I said, biology is different. There was a lack of selection of the patients with probably higher risk and more blast in the marrow who were better responders. And again, are we using this combination as a bridge to transplant? Maybe this is the clue for these kind of very high-risk patients. So what are the lessons learned? Therapy should not be empirically based and just tried. We should have more insight into the biological background. And as a consequence of this insight, we should have more stringent selection of patients. There are no therapies that fit all patients and all molecular subtype of patients. Some agents are very active for a short while, so they can be considered mainly and only probably as a good bridge to transplant, and the duration of therapy is critical. And I really don't know what is the future now, if we will just get rid of the hypomethylating agents, find a new way. The triplets disappeared from our horizon. So we are actually desperately trying to understand and to learn and build on it. And I really wish to thank you for your attention.
Thank you, Valeria. I hoped you would give better answers, but we will try. I will move on, and I would like to share with you some thoughts about clinical trials in general, how we do it, and how we interpret it, and with some focus on low-risk MDS. Now, the way that we usually do, and this is how we were trained and how we are doing now for maybe 50 years, is basic research, whether it is from the laboratory, animal studies, a good idea, is followed by clinical trials, phase 1, 2, 3. And if and when they are successful, then there is regulatory approval, FDA, EMA, and so on. And then the drug is marketed. And after all, the idea is to have the patients get the drug, not only the trials. I guess you would agree with me. So why sometimes things are not going well? Well, it could be that the drug is not effective enough, obviously. But there might be other reasons, probably related to the trials and maybe to what happens after that. And I would like here to focus on some problems, challenges, and limitations that we might come across during trials, and then talk about what happens after and when a trial is successful and the drug is approved. Finally, I would try to think about some possible recommendations. So let's evaluate the problems and limitations in clinical trials as we do it. One problem is the diseases. Unfortunately, MDS is a very heterogeneous disease, variable biology, numerous genetic mutations, some of them we heard today, different treatment response patterns. Unfortunately, it is not like CML. I always look at my CML colleagues. Their life and their patient's life is very easy, very simple. One mutation, one treatment, and they are arguing between the 92 or 94% response rate. We wish we had been in the same situation. And there is still limited understanding of the biology. We have to take into consideration that the incidence is relatively low, which means that it is difficult to recruit patients for studies, longer enrollment periods. The result is a smaller sample size, which might lead to inconclusive results, and obviously the pharmas are less interested. But it's not only the disease. It's difficult to deal with these patients. They are relatively older. They are with comorbidity, as we discussed today. So that means that many of them are excluded from trials. There are logistic problems. They are less mobile. The tolerance is not always as good as we would like it to be, which leads to protocol violation. There is a higher dropout rate, and they are less available for long-term follow-up, which is more important in patients with lower risk disease. And obviously, there is the methodology of the trials. Many of the trials are too complex. The regulation is quite tough. We all know it. And let's think about the eligibility criteria, which are very, very heterogeneous. Are we dealing with lower transfusion burden or higher transfusion burden? Are we treating primary MDS, secondary MDS? These are all different. The endpoints are very important. What are the endpoints? Now, and the markers that we are using, you know, in the past, when there was cancer trials, survival was the only one marker. It was very simple, whether the patient was alive or dead. But today, look at this list. Complete response, partial response, hematologic improvement, PFS, event-free survival, leukemic transformation, MRD, and so on. And the trials are using different and various endpoints. Quality of life, how exactly there are some methods, but they are not the same, and it's quite difficult. One of the reasons why it is so complex, or one of the proof, you can see that how many modifications we are doing during the trial just to show that the design was not really appropriate from the beginning. Now let's talk for a minute about the statistics. Small sample size. The Nobel laureate Daniel Kahneman and Amos Tversky wrote a seminal paper, not on medicine, in 1971, and they called that the law of small numbers, which means we all know that if you take a small sample, then you are prone to bias with the results and the interpretation. And we often see subgroup analysis, not always they are right. Post-hoc analysis, I will show you also, but we know the limitations. And let's say one word about the holy p-value. We were trained by the binary way. Either the p is less than 0.05, successful, wonderful. And if the p is 1.51, 52, bad, failure. Well, life is more complicated. It's not like this. One excellent editorial in New England Journal of Medicine, Evidence, about a year ago, the title was Treat Patients, Not P-Values. And another report shows that if the p-value, even if it's successful, and it is close to 0.05, if you want to repeat the result, you need 16-fold larger sample for that. So we have to be careful when we look at the p-value, when obviously it might lead to misinterpretation. Now, with the interest of time, I won't show you many examples, but I will just focus on very few, not in the MDS fields. Many of the COVID trials have been criticized, especially by the NIH. There is here a lion study with breast cancer, which was defined as failure, but the editorial shows that some subgroups did benefit from the treatment. I was involved in some of the erythropoietin trials, and it was sort of risky drug, and the oncology solid tumor do not use it anymore. I'm not sure that this is the right, because there are proof that part of the problem with erythropoietin was allowing hemoglobin to go too high, not that it stimulated cancer. and there are several other examples. But there are also examples in the MDS field. Valeria mentioned the pevonedistat first, the Panther trial, but interesting point which I would like to emphasize, I think Mikhail Sekeres presented in one of the ASH that in some subgroups, the VAF went down. So probably if the VAF went down, it might indicate that at least some subgroups might benefit from a trial that was defined as a failure and is not developed anymore. We are familiar with the thrombopoietin receptor agonists. They are not developed anymore, but there are probably 2 trials, and it is clear that at least in lower risk, it might be safe. I was privileged to lead the roxadustat trial, which was also defined as a failure. But just to tell you, I have several patients on this drug, and at least one patient went from hemoglobin of 7.5 to hemoglobin of 14. I am not aware of any placebo that might increase hemoglobin. So maybe the drug is not effective for all, maybe only for subgroups, maybe not the duration is not long enough, but obviously there are some patients that might respond. Initially, the company wanted to close the program. Now probably there is a future for this drug for new treatments. And there are several other examples saying that probably we should be careful in defining failure or success. Now there are other aspects which I will just touch briefly, such as the safety. Safety are not always reported as well. In one trial, summarizing 407 trials with more than 300,000 patients, it was clear that only 32% reported completely the toxicity. Emma Burat and colleagues reported recently that only 13% correspond with the inclusion of the toxicity. So toxicity is not always reported as it should have been. Now let's talk for a couple of minutes about what happened if and when a drug is defined as successful and is approved by the regulatory agents. Now, there are many gaps. There is a gap between the trials and real world, as we all know. One report, for example, showed that only 32% of cancer drugs that were approved after accelerated phase, indeed prolonged survival. There is a gap which is basically because real world is not what we see in trials. It is estimated that in the US, only 7% of cancer patients enroll in trials, and I can conclude that in many other countries in the world, it might be even a smaller percentage. There are certain underrepresented populations or subpopulations, minorities, people with low income, people in the periphery, in the community because they are far from the hospital, and in other countries. So they are not presented in trials, and we tend to conclude what happens in the trial is real world, which is not the case. We are all aware that industry trials are different from academic trials. They tend to recruit younger patients, healthier patients. The follow-up is shorter, and the outcomes tend to be superior, but this is not always real life. And also, novel information that is published later after the trial is completed might change things. There is limited commercial interest for some agents, especially in our field. And we also have to remember the financial toxicity. What happens to a drug that is approved, but if it is too expensive, either it is not covered or the patients cannot afford it. So what have we achieved? So, what can we do in order to change and improve it? Well, I am for evolution and not revolution, and probably we can do some things together to improve it. It should be a joint effort of all stakeholders, the academy, the pharma, regulatory, the society, and the patients. We got to better understand the biology and to move on and identifying better targets and markers. We have to improve and make the trials more simple protocols, broaden the eligibility criteria to include almost all, and by that, hopefully, the trials will be closer to real world. We have to also address the post-approval barriers, there are several programs for orphan drug. Some of them are outdated, they should be modernized according to the new tools. AI might help us in designing better trials and solving these problems. And also we have to address the issue of costs as well as the toxicity, which I mentioned earlier. So in summary, we still have a problem, but if we all work together and try to solve and to attack these limitations, we might come up in the next few years with better solutions for our patient, and the number of 7 might increase. And with that, I'll finish my part. This is what happened to one of my patients who had a prescription. The price may make you dizzy. And thank you for listening to me. And thank you. I would invite Dr. David Stinsma, who will tell us about the pharma's perspective. David.
All right. Thank you, Moshe. So I should make it clear right at the beginning here, I'm speaking on behalf of my own idiosyncratic perspective and not in any sort of official role, giving some sort of unified position for how industry is thinking about drug development and MDS and what's gone wrong over the last 15 years with this drumbeat of negative trials. And I think Valeria and Moshe summarized it very well. It's a little like the opening lines of Anna Karenina, where Tolstoy wrote, happy families are all alike, unhappy families are unhappy each in their own way. And each of these different trials, it was a different problem. It was a study design, it was a drug that wasn't active, it was the wrong patient population. COVID got in the way of a couple of the trials. So that all adds up, but the dysfunction is not just a single thing that we can fix. But certainly it is very frustrating. In fact, there was a lot of hope for the Verona trial for venetoclax that, because that's made such a difference in AML, maybe it would similarly have made a difference in MDS. And we can talk about why that study was negative, but certainly it cast a pall on industry's perspective of developing an MDS. In fact, shortly after that trial completed, I was talking to a pharmaceutical executive at a big company, and I said, what are you guys thinking now about doing trials in MDS? And he said, well, we'd rather put a large stack of money on a rusty old barge and send it out into Boston Harbor, because at least when the barge sinks, some of the $100 bills would wash up on the shore and we wouldn't lose absolutely everything as we have for many of these trials. And yeah, that's tongue-in-cheek, but I think it does express a level of frustration. Nobody's running out and saying, hey, I want to do the next big trial in MDS and spend $50 million and have nothing to show for it at the end of the day. Some of these drugs, as Valeria pointed out, might be salvaged, potentially. What if you did the sabatolimab trial again, but only did it in women? Maybe that would be a positive study. But a lot of these companies just turn the page and lose interest. And so that's the reality that we have to deal with. So yeah, 17 trials to my count. The only higher risk trial in MDS that's been positive, randomized in the last 20 years was the transplant trial from CIBMTR and the CTN transplant network. So we should transplant people if we can. It's hard to look at these kinds of figures and look at like everything that's happened in lymphoma and myeloma. Comparison is the thief of joy. Is there something inherently more difficult about MDS that's made it harder to develop? Are we, as an MDS community, more dysfunctional in some way than these other communities? I don't think so. I think there's been a lot of bad luck here. And as my colleagues pointed out, there are some things about MDS that are particularly tough, such as lack of good targets and an older population. Hopefully these things will improve. You know, when industry looks at MDS, it has been looked at as a big opportunity. You look at the market size for the lymphoproliferative disorders for myeloma, and these drug approvals have resulted in huge global sales, but MDS is a pittance compared to that, even with a couple approvals in lower risk MDS in the last few years. There are a lot of different concerns now that pharmaceutical sponsors have about MDS, and many of these my colleagues have gone through, so I won't go through them in a lot of detail, but I'll just point out that it is really hard, you know, when preclinical models don't predict things very well, when a lot of the mutations that have been successfully targeted in other diseases aren't present in this disease or are rare in this disease, and we really don't understand the biology as well maybe as some other diseases. But I think we're a lot better than we were 10 years ago about biological understanding and about modeling. And, you know, a lot of that comes down to funding. You know, like the Evans Foundation has built a huge consortium of investigators who've made some real discoveries in MDS, and so hopefully that will continue. A big issue is that a lot of small trials looked good, but then the big trials crashed and burned, and you know, we can talk about why that is. You know, some of the things that aren't as much of a concern for industry, the heterogeneity, and as much MDS is very heterogeneous, but that's true of lots of disorders, and we can often still find a red thread tying the disease together that's targetable. There is a lot of MDS here in the US and globally, and so it's not that it's an ultra-rare niche indication where there wouldn't be a good return on investment. And it's not that existing therapies are so hard to beat. One of the problems that's happening in myeloma is that you've got BCMA-directed CAR T therapies and all of these different combinations. These are really, really effective therapies, and it's getting harder to show a benefit, so you have to look at surrogate markers like MRD and progression rather than survival. That was the problem in large cell lymphoma for a long time. It's just really hard to get anything better than R-CHOP. But azacitidine is not that great. I mean, 15, 20% CR rate and median survival a year or two. So that hasn't been an issue as well. We have certainly seen this regression in the mean. I liked your reference, Moshe, to the law of small numbers. It is hard sometimes when you do a very early trial to know when is the response rate good enough to say, hey, this is worth doing a registration trial because it has a good chance of being successful. We've seen significant regression to the mean with several of these agents where there were phase 1b or phase 2 trials that showed high response rate and then that regressed. Not so much with venetoclax. The response rate, at least from the press release, we'll hear more at the meeting, was quite similar to what had initially been presented. But their cytopenias and infections, I suspect, were a problem. Andy Brunner at MGH and I and a statistical colleague did an analysis of, if you do have a small study that has 15, 20, 25 patients, when is this response rate good enough to suggest it's worth taking on a big study? And so this could be a guideline for thinking about that. I think Valeria touched on the fact that AZA-001, which led to the AZA approval, really was an outlier and a bit of an anomaly. A lot of real-world data hasn't shown the same sort of effectiveness. I think there have been, various mistakes. I mentioned jumping into big trials too quickly. A big problem is not listening to the MDS community. There have been companies who, just decided they were going to do things and didn't talk to disease experts. I remember getting a trial to review from a company that had only done solid tumors, and they were proposing doing this trial with an immune checkpoint inhibitor that had been successful in lung cancer. And their MDS trial excluded patients with cytopenias. They had no idea what MDS even was. The endpoints were all wonky. And, a 30-minute discussion with somebody like Rafael or Arjan could have set them straight. So there is a little bit of that, maybe. There's also fear of missing out. You know, sometimes whether it's an immune checkpoint inhibitor or an HDAC inhibitor, you know, one company does something that looks exciting and then everybody else wants to jump in the pool. That's not true just of MDS, certainly. You know, how many different BCMA-directed therapies, how many different calreticulin-directed therapies are there now in development in MPN? There's just a lot of fear of missing out on something big. Poor trial design, like this elevator. You know, some trials have been very good and yet still have been unsuccessful. One of the things I think has been a recurrent trial design issue has been this lack of clarity how to do dose reductions. And that was a problem with Verona. Do you dose reduce the venetoclax? Do you dose reduce the azacitidine? Which one do you hold? I think that's a real problem. I just want to call attention to this paper. We don't have time to go through it in detail, but it does have some, I think, useful practical suggestions for drug development in MDS. So in the interest of time, I'll just wrap things up. But, you know, I don't think it's hopeless, and there are still a lot of trials going on. Hopefully, we'll see some successful approvals in the next 5 or 6 years. But it just really has been, you know, I think for all of us, very frustrating that we're not in a better position for our patients than we are currently. Thank you.
So it was a complete overview. Maybe we have really to pause a moment and understand why we have so much difficulties, but also some success. We have to keep in mind that as well, especially as you mentioned in knowledge and in knowing the biology of MDS. So with this, I think we may conclude the day, the symposium. It was really an interesting, well, beginning of the day, early beginning, but I think very exciting discussion. So I really thank all the audience, but I want also to remind you to complete the post-symposium survey for CME, but also for us it's very important. And I really want to thank you and all the sponsors, and of course MDS Foundation to having given us the opportunity to discuss with peers and with you. Thank you very much, and see you next year.